Please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
Hi there.
We're such nerds sometimes, aren't we?
True.
I'm trying to get more of this side of the wall.
Oh, so you see there's Snoopy over there,
Yes.
George and me from 1991.
Wow.
And then that pencil drawing over in the corner. Do you remember the class in Calgary?
That was the class that started it all for me.
Yeah. They went down by the river and we talked about running away from a tiger in the woods. And so that is a picture of a tiger chasing them through the woods, and they all signed it. And then there's my grandson and the poems that my kids wrote. So you guys never get to see that side of the room.
That's a nice
They're
side.
Probably protecting us from whatever, or trying to get into the room.
This is a very good opener because I'm going to borrow a word from you, cattywampus.
Ah,
I figured
Cattywampus.
since the podcast diverts from the tracks and it takes a life force all onto its own, I shouldn't have to organize my list anymore. I love to brainstorm. Brainstorming has always been one of my favorite things to do, scribbling ideas down and then trying to connect the dots. Right. And I found this to be very true when I tried to write the sports course. So it's funny that you're taking us back to ground zero. So where that picture was, because back in 2013, I convinced you to come to Calgary to teach a course. And I think you almost got deported.
getting back into the United States was hard. But we got to go to Spruce Meadows and I got to see a whole barn full of Hanoverians and the jump course. And then I got to do FSM by the river.
We had an amazing class. You got to help somebody get pregnant.
Yes. And that story is still in the core.
Yes.
Trauma in the uterus. Who
Yeah.
knew?
But that was the class where I remember sitting in the back of the room because I'm going to say it was like 99.9% physical medicine students. Like they were all PTs, chiropractors, very physical. And I remember on day 3, and I think it was like the neurovisceral emotional kind of component. And I was looking at the 2 practitioners that I was working with that I couldn't wait for them to take this training. And they were on Facebook and doing chart notes. And I'm like, why aren't you guys paying attention? This is like really important. And they're like, yeah, I don't need this stuff. I just need the scar tissue stuff.
Mhm.
And I'm like, oh, your poor little guys, you don't realize that it's never the muscle yet. And it dawned on me, it took me 5 years to get there.
And that's when I changed the supine lumbar practicum.
Right.
Muscle, disc, facet, and ureter and psoas, kidney and QL, kidney fat pad, small bowel, food allergies. And part of that was the patient that we saw that weekend. So I moved because nobody's going to wait until day 5 to figure out why ovaries, kidneys, ureter, psoas is relevant to low back pain. So I moved the visceral stuff into the physical medicine stuff. And it was after that the supine lumbar practicum is traumatizing for most students because the first 3 times supine cervical, it's scripted, it always works, it's always exactly the same. And then the supine neck and shoulder, scripted 3 times, always exactly the same. Day 3, supine lumbar, you're on your own. Excuse me. And then that practicum takes the longest because they find that's where they put it together and they kind of panic. It's okay. You've got the next 2 days.
I think I had a a quicker connection to doing supine lumbar, only because I was really fortunate with my training in college. We treated supine first when it came to low back pain, and we had a lot of visceral experience. I remember there was a funny story about us learning how to do, it's called the J stroke, and that helps break up constipation. But I remember doing it the wrong way and backing somebody up.
Oops.
But it's college, so it's like a free-for-all. It's a little bit of a, if you didn't have a dysfunction in college, you left with one.
And anybody that graduates from chiropractic college without body damage is,
It just doesn't happen.
doesn't happen. Yeah.
But so, I mean, for me, that concept I think was rare, but you only know what you know. So when you're training and your experience and even your practice management kind of force feeds you into a really myopic way of thinking or a myopic way of treating, doing a supine lumbar is like, what? It's the equivalent of the toe heel walk. It doesn't make sense to a lot of people. They have low back pain. I'm going to treat their low back. So one of my little blurbs for today was funny. I was explaining FSM and what we do and the devices to somebody, and they said, so you just push buttons and tell it what to do? And I said, no, actually FSM tells me what to do. And I'm so fortunate because you're right, you have a hypothesis, you have an idea, channel A, channel B, set up the leads, and then you go with it. But FSM and the training that you've blown up and rewritten and blown up and rewritten and where we're at right now teaches you how to think about it, but it goes beyond teaching you how to think about it. And I think the biggest nugget is always going to be, why is it like this? So before it was really heavy on what's on A, what's on B. So the pathology and the tissue. And
the
yes,
people that took it the first 15 years, I'm really sorry. You really have to come back. It's different now.
but for the better. And it's not that you're not going to get results. You will. We always talk about the short term and the long term play, right? So I think that initial way of what's wrong and where is it occurring is a really good starting point, because if you can identify that, you will most likely get that person, the pain will go down, the tissue will relax, and that's great. Everybody can take a deep breath. And then you start thinking, okay, this is great that this is responding, but why did it get like this?
The results, so you have to have, so the person that said you push in the buttons and the machine tells you what to do, it's no, you have an idea based on your clinical knowledge and assessment of what the problem is, and you use the machine to deliver the correction. The nerve between S1 and your heel is not working. You landed on your butt, you bulged a disc, you have pain in your butt, and your heel's numb, and the back of your leg is numb. That means it's a nerve. I had to make that decision based on patient's history. My heel hurts and my butt hurts. What connects the heel and the butt? S1 and S2 nerve roots. Poke your wheel, test the nerve, nerve is numb. Back of the leg, numb. Then based on that, I tell the machine, do 40 and 396 for 20 minutes and 81 and 396 for 30 minutes. And at the end of the hour, S1 in the back of her leg is no longer numb. Her heel is still numb. And I don't know why. So I'll figure that out tomorrow. I've seen her for 2 days. She did land on her butt, and she had a trigger point in her gemelli. She landed on the ischial tuberosity. And the gemellis, the piriformis, and it wasn't the glute max, it was deeper. So it was piriformis and the gemellis. And I treated what happens when you are in martial arts, you put your foot out to kick, your other foot slips out, and you land from 3.5 feet, short legs, onto concrete. What happens? Torn and broken. You put your hand on the patient's butt, there's this big knot there. Torn and broken in the connective tissue. We all looked, we got Netta out, we looked at the muscles, and she said, yeah, it hurts right there. Well, that's the periosteum and the connective tissue. And then remember deep old bruise that we hardly ever use anymore? That's what did it.
I bet.
I had to treat the tendon, had to treat the periosteum, but there was still a lump in the middle of the piriformis and the gemelles. And I thought, can't be. 284 and 62, deep old bruise. And this thing is 13 years old. And she said, yeah, my butt's always sore. Took me that long to figure out that the task of the core is to teach you how to think so that you can decide what the frequencies can do to help you and the patient. I got to ask you, was there a memo about turquoise and navy? Never ever worn turquoise and navy.
I noticed that when you came up. It was just like, we really don't plan this podcast. From once in a while, we get to chat on the phone throughout the week, but that's not very often. It's never, okay, we're turquoise and navy.
Oh, and we're always either black and white or white and black.
We are pretty basic like that.
Except today was just turquoise and navy day.
Super interesting. I had said about her heel is numb and I'll figure that out tomorrow. I think that's a really important statement that you blew through, but for the practitioners that are listening, we get really caught up in trying to fix everything all in one day and all in 1 hour and all in one treatment. And that's just not the way life works or any practice works. Yes, it's very helpful if you have a bunch of hypotheses and you can start thinking about, okay, what's going on and how are they responding? How did that tissue get into that state? But there's so much of the story that ends up coming out at treatment 8 or year 2. And that's no fault of the practitioner. That's just memory sometimes.
And she was ecstatic that the pain in her butt was gone.
Sure.
That not the numb heel, she's just used to it. She didn't even know that the back of her leg was numb.
Right.
So the back of her leg is no longer numb. She doesn't miss that because there was no pain. It was just numb.
Right.
No muscle weakness.
Right.
So we got 2 things off her list. And I don't know why her heel's still numb. So maybe it's just the skin on her heel is denser and I need to push harder with the pokey.
Sure.
That's pretty cool. The lane change.
Do it.
Okay.
Back.
So her husband is also a patient and he had the most complex cervical spine surgery I've ever seen. He took the core online, then he came to the Practicum in San Francisco with his MRI, and he said, before I see a surgeon, I wanted to see you to find out. So he came to the San Francisco Practicum. I wanted to see you to make sure I needed to see a surgeon. And I looked at his MRI and went, so he had disc bulges pressing on the spinal cord at 4 levels, front and back. And he said, you did my reflexes, hyperactive reflexes, and then you felt my legs. And my legs were tight. And you said, yes, you're surgical. So he hunted around, found a surgeon in Florida that did an anterior disc and fusion insert at 3 levels, 4, 5, 5, 6, 6, 7. Great. Then rolled him over. And because the patient had osteoporosis, they couldn't do a laminectomy to get the bone off of the back side of the spinal cord.
Wow.
So they removed the lamina and put in prostheses to replace the lamina that was pressing on the spinal cord. I've never seen anything like it.
Wow. I was just going to say, I don't know much about that. How common is that kind of procedure?
I've never seen, I don't know who else does it, but it was brilliant. The patient's only complaint is, I'm numb here. And he pointed to C4. So the first day, he was numb clear across the length of C4. So I ran 40 and 396 and increased secretions, and it was still numb over here. The second day he came in, and the numb place was here, and we measured it. It was 11 centimeters by 6 centimeters. It was an oval on C4. So I treated from his neck to his shoulder while I'm working on his armpit on the other side, and ran 81 and 396 for the 30 minutes that it took me to take apart his right shoulder. Went over to the left side, and it was now 3 centimeters by 4 centimeters.
Wow.
So use the pokey wheel, and I made little ink marks. And then while I worked on that shoulder, I ran 81 and 396, and it was now 1 centimeter by 1 centimeter. There's a thumb size numb spot. And maybe it wasn't so numb. He got up and he said, "Oh, this is numb." I said, "That's T2.
Hmm.
And then on the way home, I thought about, how did T2 get numb? Wait a minute. Because it's his arm, T2 and T1 in his arm are fine. It's just the proximal part of the nerve. If you're going to do an anterior disc and then you roll the patient over on their stomach, what happens to their arms and the T1 and T2 nerve root as you're replacing the lamina from C2 to C7? What happens to T1? So I have a plan for tomorrow, and that is treat the T2 nerve root, because the posterior contact has to be where the nerve comes out. I didn't have anything down as low as T2. So tomorrow I put it at T2 in the back and at T2 in the front, and see if we can get rid of this numb spot. There's no pain, it's just numb. So you figure it out as you go along, and you take the patient's history, what happened, and it's tell me a story about. So I'm telling myself a story about, how did T2 get numb when his neck is fine. It's the most amazing surgery I've ever seen. His reflexes are fine, upper and lower, all +2s. But T2 is numb. How did that happen? Ask yourself. So you're right. It doesn't stop at the first treatment. And it never doesn't work.
Those are like the haunting words, right? Because that's what keeps you humble. It keeps you continually looking for the breadcrumbs to follow, because nothing is ever a closed case. And I want to touch on that a little bit, because we seem to think that the successful treatment is get them in and get them out and never see them again because you fix them. And that's not how it works. That's not how therapy, that's not how anything from chiropractic to PT to massage to acupuncture to whatever life. We are a continually evolving, ever changing
process.
So I think we have to take the pressure off ourselves as practitioners to fix people. We are helpers in their journey at whatever stage that they're in. So whether that's something really simple like an athlete and during the season versus an off season, that's a completely different set of treatments that you give. Or somebody who is coming off of a very complex chronic injury and their initial set of symptoms, burning pain, numbness, whatever, changes. And now it's this little spot that is irritating, or range of motion changes. They saw you year one for frozen shoulder, you fix that, and now they have a neck problem that they probably always had, but the frozen shoulder was
The noisiest.
right.
And
So
in my life, they come in with 6 things wrong. And day one, you do drive-bys on 2 of those things and you fix 2 other ones, and there's 2 left. We'll do those tomorrow. And then the 2 you did drive-bys on, you do those the next day. And because my patients are so compressed, I have them for 4 days out of 5.
right.
And in the real world, you see them twice a week for 4 to 6 weeks. For people that have normal practice, sometimes I long for that, but not very often. And you treat what's in front of you and you treat what you can. You treat the worst first,
Mhm.
because that's the patient's priority.
Right.
And then treat the contributing factors. It's like there's 2 parts to pain. How much does it hurt and how much do you mind it? So
Yeah.
the how much you mind it is concussion and vagus.
Mhm.
And that's one custom care in 47 minutes. So you got nothing to lose.
It's funny, the how much you mind it can really cloud the pain scale sometimes. And so I feel like sometimes you have to really help clients and patients explain the pain, because nobody's walking around at a 9. They're super irritated that they have their irritation is at a 9 out of 10, but the pain isn't.
Right.
So that is 2 different
And
trajectories.
sometimes it's hard to explain that to a patient so they don't feel invalidated.
Sure.
So it's like she said, my pain's a 9. Okay, you see this scale? When you are a 9, you are sitting in the corner, curled up in a ball with a morphine drip, or begging for morphine, unable to talk,
Right.
crying, moaning, rocking. That's a 9. Oh, I'm not there. Okay. Then I'll give you that you mind it a 9.
Yep.
How much does it actually hurt? And then I show them the smiley faces and the colors. We've got that pain chart thing that you can get on the internet. And they go, oh, it's right about there. Okay, so your pain is between a 5 and a 6. You act like your pain is between a 5 and a 6. You're moving, you're talking, all that, but you mind it a 9. That tells me it's either bleeding or it's a nerve. What? Yeah, nerve pain is the only thing really that hurts like a 9. Really?
Yeah.
Oh, okay. And then we do the physical exam and find out what it really is.
Right.
And
when they mind it a 9, your go-to is concussion and vagus.
yes, to take care of the minding it part.
And do you think that in your experience that lasts long, or do you have to go into some of the other maybe emotional frequencies, or do you?
I'm really bad. I've gotten, unless it's really obvious, there's a specific emotion involved. This all started last August. What happened in July? Well, my dad committed suicide. Okay. So you know for sure there are 970s involved there.
Yeah.
Concussion and vagus. And then I'll run the 970s more or less by hand.
Mhm.
As on the tissue as I'm going along. The vagus is turned down by infection, stress, and trauma. Pain is a stressor. If you have a partial thickness tendon tear in your shoulder or your knee, or your ankle, that's constant trauma. There are little teeny cells or flakes coming off of the torn tendons that the vagus nerve picks up in the blood vessels. And the vagus nerve is telling the midbrain, there's busted things here. And the midbrain says, obviously there's a tiger. So you just quiet down, midbrain amps up, turns the vagus down. And when the patient's pain level is a 6 and the vagus is downregulated, they come in with their pulse. So the little pulse oximeter, how do you tell if the vagus is working? How much do they mind it? And their pulse is 78 or 84. Vagus has as its job to quiet the pulse. Midbrain tells the vagus to quiet down. Vagus stops telling the midbrain that everything is okay. So the midbrain is freaked out. That's how much you mind it. As long as there is infection, stress, or trauma, they're going to mind it.
Mhm.
And the vagus will, at least what I know about the vagus, will be downregulated, just as what it is. Yes, you have to fix the owie. Pain is a stressor.
Yeah.
So if the pain level is 6, no matter where it's coming from, that's stress.
Yeah.
And that's going to tell the midbrain there's a tiger.
Right.
So we're back to Calgary and the tiger chasing it through the woods.
It's so cyclical all the time, right? We're always thinking about where we started and where we're going, and we get back there, and how long we stay there depends on where else we have to go. We have a couple questions, so let's go to some questions before I go into my list anymore. Leaf, any clue on unilateral cystic kidney?
Yeah. They're usually genetic. Polycystic kidneys usually have a bunch of cysts in them, and they're bilateral, at least the ones I know about. It's not anything I've studied since the last time I studied. The unilateral kidney cyst is either, so if I had to guess, infection or physical trauma. The patient knows they have a cystic kidney because somebody did an MRI and ultrasound, and they have symptoms. Then the next question is, what happened on that left side? Did you take a blow to the kidney? Do you have an infection? You can live very nicely with one kidney, so I wouldn't worry too much about it. If the kidney has a cyst in it, part of the kidney still works. The part that has a cyst doesn't work, but the rest of it is functional, usually. Blood work. What are your kidney values? Dipstick. Do we have protein? Do we have blood? Do we have white cells? Data is your friend. Ultrasound. No known cause, no blow or infection. I don't know. Sometimes people are just born with cystic kidneys. One practitioner at a seminar had one kidney that was really small and just made stones in its spare time. He had kidney stones all the time. And they finally just took the kidney out. It's more trouble than it's worth. I don't know, Leaf. You can treat it if it's uncomfortable for inflammation. And I've never had cystic condition do anything. It's one of those frequencies, 59 and 131. I'm still looking for something they're good for because they don't take cysts away. So there's that. Okay. Oh. Okay, why don't you take this one?
Okay, potential patient has untreated torn rotator cuff now causing muscle to atrophy. She is 1.5 hours away from closest FSM practitioner, looking for more conservative treatment than surgery recommended by orthopedic surgeon. She wants to know how FSM can address this type of injury that is several years old. Her profession was a telephone repair tech, climbing poles, carrying, lifting ladders, 28-foot ladders, retired in 2007. So the injury is most likely pre-07. It's only bothered her enough to seek treatment in the last couple of years.
Here's the thing. Here's the untreated torn rotator cuff tendon. If it is a complete tear, you can't treat it. It's done. If the muscle is atrophied, pretty good chance it's a complete tear. It's surgical. If they refuse surgery, they live with whatever function the rest of the shoulder can have. They live with whatever pain they have. And that's about that. But that's partial thickness tears. If everything goes well and we do FSM and we do taping and we do appropriate kinds of exercise, partial thickness tears, we have pretty good luck with. As long as it's a partial tear, it usually goes pretty well.
Yeah, I would agree. So it'd be the severity would be the first thing that people tend to dismiss on the history. They'll say, I have a torn rotator cuff, but tear is not all created equal. And some
Yes.
people will say, yes, imaging will absolutely show the degree of which the tear is. That'll be one of the first things that you'll see is the grade. That's the important thing that you highlight and look for. Because like you said, 100% tear is 100% tear. FSM is good, but it's not that good. But with a partial thickness tear, you absolutely will start to see atrophy in something that is that old because things are inhibited, right? When there is a tear, it hurts. And when it hurts, we don't move it. And when we don't move it, we get atrophy. That's one avenue of looking at it. First step is to get the imaging or the report at least to see. And I would want to see if it was imaged in 07 versus if it's imaged now, what things look like, because things do tear and they tear 20 or whatever it is, 16 years ago. And then when they heal, they scar. And when they scar, it hurts to move it. And then you get atrophy because you're not moving it. So there's two different, like you should be thinking about numbers already. So yes, 13 is scarring, 124 torn and broken. So first steps first, severity of the tear, and then you can really see. But then I would also make sure to see when the last imaging was done.
Yeah, and it can start out as a partial thickness tear. And if you do an unguarded movement, you can take a partial thickness tear and make it a complete tear.
Yeah.
And even when you're treating a partial thickness tear, the supine neck and shoulder, you can't fix supraspinatus, infraspinatus, teres major, teres minor without releasing the subscap. So in my world, I always start with 13 and 396 in the armpit anyway.
Absolutely. So that's, I think, what people want are this, like the recipe where to start. So there's so many phrases that stay in my brain over the years. And one of them is you will never tear a nerve. Like your nervous system will never allow you to tear a nerve. So if that nerve is scarred, that's going to cause a whole host of things from inhibition to pain to both of them creating the problem. So a lot of times with frozen shoulder, we see that it started from a partial thickness tear that caused scarring, thus caused inhibition, whether it's from it hurts, so I'm not going to move it, and then it's scarred, so you can't move it. So there's a sequence involved with frozen shoulder and partial thickness tears. And this is one thing I'm absolutely in love with treating because it works so well. So whether it's 16 years old or 16 months old, there's just so much that we can do. But to get the full story of when did it tear and how severe is that tear would be the first steps.
And there's one little caveat, and you won't see it very often. So I honestly don't even talk about it, even in the nerve pain section of the core, because I've seen maybe in 27, 30 years, I've seen 3 actual torn nerves. One was the cutaneous branch of one of the abdominal cutaneous nerves, something femoral. Anyway, the patient was backing up, walking backwards, and he was in a carpet factory. He fell backwards. How the carpet rolls are maybe 3.5 feet, and he was about 5'5", and his feet got caught and he fell backwards over this roll. And the end of this nerve was tethered in his appendix scar.
Wow.
And you do a sensory exam, and it's not dermatomal. So there is one dermatome map that I have that has dermatomes on one side and cutaneous nerves on the other side of the body. And there's this oval that matches the place where he is exquisitely painful. And the area is numb and hypersensitive at the same time.
Wow.
Good word. That cutaneous nerve comes out of L3 to L1 probably. And I treated the nerve, got the pain down. It was still numb and hypersensitive. I treated him twice and I said, the nerve's torn. Can't get it done. And these days, that was before I knew about 40 and 89, because basically when you tear a nerve, the other one I saw was somebody in an auto accident, seatbelt, got hit from the side, spun this way, and actually tore the T2 nerve root in the back.
Oh.
And neurotemesis is what it's called, torn nerve in Latin, and numb and hypersensitive. I didn't know what to do about it in 1999. These days, I would try 40 and 89 because it's the equivalent of phantom limb pain.
Right.
Right? So maybe it would work, but I haven't seen one in 25 years. Just a little sidebar.
Yeah. But that's from trauma, right? That's from nothing that you can't avoid. That's an unavoidable trauma.
Everything else you said is absolutely true.
We're talking about, I'm not just going to abduct my shoulder, rip. Now, there will be multiple neurofeedback mechanisms in place to prohibit that from happening.
Yeah, it's like the brain said no. So,
yeah, not today.
Yeah.
So yes, I think it is worth going to somebody to get imaging. Going back to that shoulder, if it's within the last little while, I think you're fine. I just would make sure that imaging is quasi-recent, just to know what you're dealing with, because that will help dictate where to start.
A partial thickness tear that's 20 years old it just takes longer.
You said that person was far away from an FSM practitioner, but there is so much they can do at home with, let's just say it is scarred or there is scarring, to self-mobilize with FSM. We did it during COVID with so many patients. So you can get a myoball or a foam roller. You can do active range of motion. You can, like I said, self-mobilize. So there is a lot you can do kind of distance with those patients.
Just take a leap and tell her to drive an hour and a half, rent a hotel room, stay for 5 days, and see what you guys can get done.
Yeah. Do the maintenance kind of work at home.
Do the other stuff at home.
Yeah, I think something that is that old, you're not going to, again, going back to, you're not going to fix it all in 1 week. You'll make a substantial dent in it and you will help them out. But this is, as you lovingly refer to, a maintenance problem. And it's not a problem. It's just maintenance. We all just need maintenance.
Yeah.
So,
by the time you're my age, you're like a car with 250,000 miles on it.
hey, that's my car runner and we're doing just fine. So
yeah. Replace the belts, make sure it has good tires, feed it good gas, and change the air filters, and
you'll be fine.
Just like bodies.
Just like bodies.
Can a tight waistband on pants cause or contribute to low back pain? In which case, is it a matter of, no, I wouldn't think tight waistband is going to put your back, it's going to compress the lumbar facet. It have to be really tight. Number one, buy a next larger size pants. Number two, or loosen your belt. But my guess would be facet. If you tighten that waistband, doesn't it put you in extension?
Yeah, I don't think you would flex into something tight, right? You would try to extend out of it. That's just the way I'm thinking right now.
Yeah, and there's a belt. Let's say you have a belt that's really tight. You're going to crank on it. And in order to accommodate it, I don't know. It's either going to be a facet or a disc. Because I could see it going either way, depending on how the person is built. They're really slender and they just have tight pants, or do they have a big belly and they're tightening their pants? Is it going to put them in flexion or extension?
That's a really interesting question.
Dana, you come up with good questions. I like this.
All right, Annie. Patient waiting for ACL and MCL repair 4 weeks in the future. Injury was 7 days ago. Are there any frequencies recommended not to run prior to his surgery? This is not an odd question. We talk about this ad nauseum in the sports course recently. So there is an increasing trend right now to postpone ACL surgery until the inflammation goes down and range of motion is restored. I love this concept. I will tell you why.
Of course.
You'd be surprised how many people demand surgery right after ACL tears. And they have this huge knee that can't go into extension because of all the inflammation. And the surgeon just wants to repair it really fast. Here's the factoid, folks. We can live with a detached ACL. This is not a bursting appendix that needs to be rushed into the OR. We have a lot of arthritis due to some joint instability, absolutely, but you can live with the torn ACL. So right now we're seeing the trend of an ACL rehab has really varied in the last 15 years. We used to see 6 months, and then we were on 9 months, and we were back to 5, and now we're seeing 1 year. So 1 year to return to sport.
After the repair?
After the repair.
Okay.
So we're seeing a bunch of failed ACLs cropping up on the group that was being told 6 months to clear. And we're seeing more of this in sport. So those, and we look even deeper into these studies, and we're seeing those people that were coming back at that 6-month mark were perhaps rushed into surgery before they had a decrease in inflammation and a decrease in extension.
Inflamed tissue is not strong tissue.
Exactly. There's so much, what I just think of it as noise and activity. Let the joint heal a little bit. Is the ACL going to repair itself? No, you still need to have the surgery, absolutely. But get the joint and the muscles the healthiest and the strongest that you can. So Annie, for your question, there's not a lot that I would not recommend. Something that's really swollen, you load it with 81. What we
40, 20. And if you think about the ACL, is there any way to tear an ACL without doing trauma and torn and broken to the meniscus?
Or the periosteum, absolutely.
The periosteum. And then think about the tendon that they're going to
harvest.
That's the word. Harvest to create a pretend ACL. And so you want that tendon to be healthy and not torn and broken, because is there any way to tear an ACL without straining the hamstring tendons that you're about to take a graft from? It's no.
And even if they're doing a prepatellar graft, or even if they're doing a cadaver graft, which we will see in an older population, we're not seeing ACL cadaver grafts in younger populations because they fail. The next set of fun frequencies to use, or your trajectory, should be like, absolutely, where are they going to harvest? Is it going to be patella? Is it going to be hamstring? Do you want to make those hamstrings as strong and as juicy and as pliable as possible? So When they're doing the rehab, your goal is to get the inflammation out of the knee first, really work to get sure they're getting 100% extension in the knee. When they get range of motion and inflammation goes down, really work on a good exercise program to get strength in the joint. So not only just the muscle and the tendon, but that's going to help strengthen the capsule. You're going to get good inflammation in, good inflammation out. And it's all about that electron exchange.
You do isometric exercises because you don't want to be reefing the joint around.
You can actually.
That's valid.
100% ACL tear, even with my own daughter. She was deadlifting heavy rep maxes of 4 to strengthen up the hamstrings with no problem. So everybody is a bit different. You have a young athlete, that ACL, yes, you're going to get anterior, posterior glide for sure, because there's no ACL intact. So they're going to have a very positive drawer test.
Yeah.
However, slow and controlled, right? They're not sprinting. There's not massive directional changes, but you can absolutely train those joints with low.
The quads, absolutely.
Nice. And as we talk about a lot, eccentric, nice, slow and controlled eccentric to gain hypertrophy.
Eccentric is your friend. And there's actually good data on eccentric contractions as a way to repair partial thickness tears.
Yes.
It's more effective than PRP.
Correct.
I went to one meeting where there were competing papers about Achilles tendon tears.
Yeah.
The best data on an Achilles tendinopathy or Achilles partial thickness tear is on eccentric contraction. And then it's like, how do you do eccentric contraction? It made my brain hurt because that's what I had. And it's you stand on a stair and you drop your heel.
Tension under lengthening load is what we want to see. This is my happiest place.
And just for those of you that are overwhelmed by this little deep dive we just took, there's always more to learn.
Yeah.
So that one factoid, you're going to use not just in the Achilles, eccentric contractions. Remember in the core when we're doing the neck and we're trying to strengthen the suboccipital muscles. So how do you eccentrically contract these little teeny muscles that connect your occiput to C1 and C2? You have to lengthen them, but you have to lengthen them against resistance. How do you create resistance? So what's the exercise we do? Put your fingers under the chin and have the patient push. I've never seen it in a book, but it was the only way I could figure out to do an eccentric contraction of the suboccipital muscles. The basic principle, and then it's a factoid.
And what I had just said about these studies, there's a study for a study upon a study. So I'm fully aware that I'm going to get inundated with some emails to say, actually, we're now at 4 months for ACL rehab and every surgeon's a bit different. I just know what the surgeons I talk to, what they tell me and what works right now in this moment with the athletes that I see.
There were meetings that I went to where every A is the thing study that was presented in one talk, there was a contradictory B is the thing and A doesn't work.
Yes.
A is the only thing and B doesn't work. And they both have papers.
And I think the more information we can get and use, and again, it's just about connecting the dots, and what works for one person is absolutely not going to be the same, and life would be super boring. Kate has such a great question that I was just going to talk about. Kate says, with all tendon tears, do we need to take into consideration age, hormonal changes? Okay, we're both so excited, but I just have to say, because we're going on the ACL, we are seeing this huge uptick in ACL tears with females between the ages of 13 to 16. And there's all these hypotheses. Why are we seeing girls doing this? One of the theories were, as they are going through puberty, their hips are widening. So as their hips widen, their knees are going valgus, and it's creating some structural changes that are hard on the ligaments. I can get behind that. I'm a biomechanics girl. Another paper came out saying that no, it's all the artificial turf when they're not playing on grass. So once the foot gets planted, the femur is still going, the foot doesn't slide, they get locked up, there goes the ACL. But the most fascinating new theory is that so many of these girls were 1 week before their period, or they were on their period at the time of the ACL blowing.
That's the one my money was on.
Yes.
It's the hormones, because when you're estrogen dominant, you're inflamed. And teenage girls, their ovaries aren't that serious about progesterone yet. They're just like, yeah, whatever. I'm not going to get pregnant. I'll make progesterone more when I'm about 18 or 19. And so they're estrogen dominant, and it's definitely related to their menstrual cycle. When estrogen is high and progesterone isn't, and they're not making as much testosterone as they will when they're older. So yes, all of the above.
It's so interesting. Weak ankles are just hormones. Oh, there's so many girls that do have weak ankles, but I'm not sure. I don't discount it. I know weak feet and weak ankles are due to the crazy soccer cleats that they're wearing right now. There's not a lot of flexibility in them. They're so stiff, but I don't know. I can't.
And I'm not sure what a weak ankle is. The other thing on a 12-year-old female is check, and she's in karate, check the Baton points, check for hypermobility. So I could dislocate my shoulder, and I sprained my right ankle so many times in volleyball and sports when I was in high school that it finally healed when my dad taped me from the ball of my foot to my knee, the way he had been taped in football when he was in college. And I complained and moaned, and he said, it's 5 weeks, just wear it. Never sprained my ankle after that.
Wow.
So it's stabilizing the ankle ligaments. If you look at the ankle, the foot is so incredibly complex. The tarsals have to decelerate to pronate. And that means that the talus and that, I think it's the cuboid, has to roll. And then a millisecond later, it has to supinate.
Yeah.
And so it's constantly rocking. There's no muscles involved.
Right.
There's flexors, there's extensors. And the thing that holds the ankle together are ligaments and one band of connective tissue that holds all the posterior tibial nerve, that whole tarsal tunnel thing.
Yep.
So I guess you can strengthen the tib anterior, strengthen the posterior, do muscle exercises, but stabilize the thing. Derek, getting excited for the masterclass. Oh, the big box arrived today. Yay.
I'm so sad I won't be there this year, but I will be there next year.
Kevin's packing, and Danielle and Wendy get to come for the first time. They've never been to Hawaii before.
Oh, so good for them.
Yeah. And they're coming to Rome, both of them.
Great.
Yeah. This is the travel cookie. That's exciting. Thank you, Derek, for hosting us. Yay.
We are out of time.
No, seriously.
My alarms don't lie.
And there's Snoopy that says, oh, wait, I got to move this camera. Anyway, depot bruise, bone marrow. Hi, John Miser. Yeah.
I will not be here next week.
Unless, do we want to try and do it from the hotel?
We could, if you feel like you got stuff to say.
You always have stuff to say. I can give you the list.
Two pages of Kim's question. Okay. That just means I have to go back to the hotel after class, and that's 3:00. Oh, that's easy. It's 6 o'clock in Hawaii when it's 3 o'clock here. Oh, so we'll have dinner in Hawaii and
Debrief about your class. And if you could just pick one thing off my list, that might make me feel better.
I would like to make multiple check marks on your list and make you feel very happy.
I always feel happy when I talk to you.
It's only taken 2 years.
It's just been 2 years.
It was funny. I had somebody ask me, how do you co-host a podcast and who comes up with the content and how do you, I'm like, it's not hard. It's not hard. We have way too much content and just not enough time, actually.
Yeah.
A good
And there's this mind meld that happens turquoise and navy.
How did we do that?
I don't know. It's like I really like these earrings and I like this Monet shirt, but it's cold. So I wanted to wear, so I grabbed my blue FSM sweatshirt.
It worked. These are one of my favorite earrings. So thanks
Okay.
everybody once again for coming. Have a fabulous time in Hawaii. I will see you
After. And everybody in between now and the next time, do good things.
fun. Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.